Good morning, everybody. Thank you for joining in so early in the morning. I was asked to present to you the management of coronary disease in patients with malignancies. I'm an interventional cardiologist at Washington University School of Medicine, and I have the honor of actually working with Dr. Alvarez and also with Dr. Lenehan, which have opened my eyes to the management of these complicated patients that we encounter. So without further ado, why don't we get into the lecture? And I've organized it in such a way where there are some spots for questions, or if not, we could just take the questions towards the end. From my perspective, I have no financial conflict of interest related to this talk. And the objectives are primarily to understand the effects of chemotherapy in the coronary circulation, and then to identify the tools utilized to select treatment strategies for patients with concomitant coronary artery disease and cancer. As we know, life expectancy has increased, and unfortunately, as people tend to grow older, they also tend to develop a larger amount of either coronary artery disease or cancer, which are the leading causes of mortality around the world. Now, in addition to that, we're actually the victims of our own success, because the advances in cancer therapy has advanced in such a way, we have now been able to improve the survival of these patients dramatically. And as such, we have also learned that some of the therapies that are applied initially to treat the cancer, or that were applied initially to treat the cancer, have some long-standing consequences that affect the overall cardiovascular system. And then in addition to that, by making people live longer, these people tend to develop coronary disease, a marker of their own aging process. So we know that in the treatment of coronary artery disease, the presence of cancer, either active or in remission, has always been increased with major cardiovascular events, with an increase in cardiovascular mortality. Specifically, when we talk about a percutaneous coronary intervention, we know that there is a higher rate of target lesion revascularization. And because of the medications that are utilized in order to prevent stent thrombosis or to allow for the appropriate endothelialization of our endovascular platforms, we do have a large component of major bleeding. So if you think about the patients that we encounter, we have patients who have, on one side, an oncological process that in itself tends to increase inflammation dramatically. In order for us to control this process, we then apply some therapy, be it radiation, immunotherapy, hormonal therapy, or chemotherapy in general, which may have some underlying effects in the cardiovascular tree. In addition to that, because of the underlying tendency or because of the underlying therapy that we apply, we are more prone to other blood dyscrasias, either a coagulopathy, thrombocytopenia, or anemia, that inherently will affect the presence or the manifestations of coronary disease. These problems are seen in patients who have other risk factors, i.e. diabetes or smoking, potentially obesity, which are all risk factors for underlying coronary artery disease. And the combination of all of these factors, particularly in the setting of uncontrolled inflammation, will lead to progression of atherosclerosis or potentially a rupture of plaques that would then create acute coronary syndromes, which makes the patient who has both coronary disease and an oncological process specifically vulnerable. And hence, it's important to really understand this more thoroughly. As far as the medications that we use to treat oncological processes, we know that there are specific therapies that can cause vascular dysfunction and endothelial dysfunction. We know that the 5-FU and 5-FU derivative coronary chemotherapies are associated with significant vasospasm and potentially can cause marked amount of angina. In addition, there are others, like cisplatinum, for example, that may cause endothelial injury and/or accelerated atherosclerosis. On the other hand, any therapy that creates marrow suppression will cause anemia and thrombocytopenia, which would increase your risk of bleeding. And finally, there are others, particularly the immunotherapies, that actually can cause significant amount of hypercoagulable components, which would then precipitate in situ coronary thrombosis. So we have to take into consideration what type of therapy the patients are undergoing, so we can potentially try to predict what type of complications we will be seeing. On the other hand, we know that radiation therapy has some devastating effects in the arterial circulation. We're fortunate enough to have advanced in the use of radiation therapy, but I'm sure we all remember the effects of cobalt chromium in the coronary tree or in the aorta. I mean, patients have a complete porcelain aorta if the upper part of their thorax has been radiated, or potentially in patients who had radiation therapy applied in the past, when the doses were not appropriately focused, you can have very severe problems with osteocoronary disease, particularly the left main or the right coronary artery. But in addition to that, because of the field where this is affected, you can have intrinsic abnormalities within the pericardium causing pericarditis, or potentially the myocardial cells causing significant restrictive components to it. So when seeing a patient who has had cancer or who is undergoing chemotherapy, I think we have to look as cardiologists what their overall risk factors are, and then treat them as patients who may develop coronary artery disease because of their underlying risk factors. And then in addition to that, we have to add the component of the effect of either cancer or cancer therapy that can then affect their cardiovascular health. So from an overall perspective, patients should have a yearly evaluation unless they're, actively symptomatic, from a pre-screening perspective, once we define their cardiovascular risk. And we work like any other type of patient. We would want to minimize or mitigate their risk by statin therapy, the utilization of aspirin for secondary prevention, blood pressure control, things of that nature. But once the signs of cardiovascular disease begin to develop, then I think it is important to then go ahead and tackle how to further define these disease processes, whether with a myocardial scintigraphy, a coronary angiogram, cerebral angiography, or a CTA with distal runoffs, depending on what we are seeing. But it is important to target that type of the evaluation pending the type of immunotherapy or chemotherapy that has been applied. If we specifically look at percutaneous coronary interventions, as we had said earlier, the prevalence of both cancer and coronary disease continues to increase over time. And we've seen that over that decade from 2004 to 2014, there's almost a doubling of the amount of percutaneous coronary interventions that have occurred in this patient population subset. We also know that if you take the most common non-liquid malignancies, we see that each one of these malignancies have some intrinsic characteristics that would put them either at risk of bleeding or mortality, depending on where they are at. Patients who have lung cancer have a higher risk of mortality in the short and long-term process, as compared to, for example, those patients who present with colon cancer, who would more likely have a higher risk of bleeding after percutaneous coronary intervention. Everyone is at risk, but these specific subtypes potentially will increase the specific risks per se. And interestingly enough, it's mostly a matter of mortality and bleeding, but there is no higher incidence of stroke between them. Now, if somebody has metastatic disease, then all outcomes are completely different. Presence of metastatic disease, irrespective of the type of cancer that you have, will always be associated with a higher risk of bleeding complications and a higher risk of mortality. And as you can see in this graph, overall, it appears that patients will have around a 10% chance of having one of these complications. If we talk about liquid malignancies, in particular, lymphoma, we can see that overall, once again, there is around a 10% chance of having a complication. And these complications are much more specific from a TI or a stroke perspective. The others are relatively common from what we had seen before. So once again, you are dealing with patients who have competing survival risks. There's the risk of the neoplasm that has intrinsic risks as far as what the disease process goes and the therapy, versus the competing survival risk of coronary artery disease, which varies significantly between patients who have a stable versus unstable symptom. In patients who have stable coronary disease, a potential medical therapy is going to be much more impactful in their survival, in their symptoms, while in patients who have an acute myocardial infarction or an acute coronary syndrome, maybe a percutaneous type of intervention may be much more warranted and be more effective. So when trying to choose who we should perform coronary angiograms on, I think it is important to know what their overall survival will be and what we want to achieve. I think elective PCI and potential coronary angiography is important to do if patients have a greater than 1 year survival. And we mostly want to do elective revascularization only when optimal medical therapy has failed. And optimal medical therapy is very varied, as you can see here. OMT includes obviously beta blockade and calcium channel blockers to help facilitate coronary vasodilatation and potentially decrease in oxygen consumption. Anti-anginal therapies like nitrates or ranolazine are also quite effective. I think one of the treatments that is sometimes forgotten is the treatment of anemia. And unfortunately, oncological patients have a high burden of anemia or anemic disease. And it is the oxygen carrying capacity of the red blood cells that actually may affect the presence of ischemia dramatically. And it may not necessarily involve a procedure that has significant risk to it. And then if
Alan,
yes,
Alan, this is Dan. Thanks a lot, of course, for such an excellent lecture, which you've done so far. But this question right here, I think, is one of the biggest issues that we deal with. And as you know, since we talk about this pretty much every day, but in the description of optimal medical therapy, if you look at the interventional trials, like the ischemia trial and others, that included aspirin and Plavix. Now, they didn't mandate aspirin and Plavix in the ischemia trial, but they highly encouraged it. So roughly about 70 or 80% of those patients were on the combination. And especially in our patients who have, may have either ongoing chemotherapy or they have pancytopenia of some variety, and all those issues. What do you consider aspirin and Plavix, for example, to be part of optimal medical therapy? And then for example, what cutoff would you make where we wouldn't want to use that therapy?
So, Dan, I think that's a critical question in the management of these patients. I think optimal medical therapy has to be a combination of things. I think you can work directly on the vasodilatation properties of medications, and then you can focus on the antiplatelet component. I think the administration of clopidogrel in addition to aspirin, in patients who have a high amount of thrombocytopenia or are prone to become thrombocytopenic is very risky sometimes. Because even in patients who have normal platelet counts, their main complaint is this nuisance bleeding. You know, a little bit of bruising here and there or some mild nosebleeds. But that is with normal platelet function. In patients whose platelets are less than 100 or even less than 50, adding clopidogrel will definitely cause a large amount of these complications. So I normally don't want to add or don't recommend to add clopidogrel unless we know exactly what the coronary arteries look like. Specifically, I think if you look at older data from the CURE trial, the administration of clopidogrel was mostly done in patients who presented with an acute coronary syndrome. But elective angina or increasing angina without positive cardiac biomarkers, I think there's a little less benefit from that in a higher risk of bleeding, particularly in patients who have thrombocytopenia.
Okay. Yeah. No, I know it's hard to make a general statement because each patient has their own individual characteristics, but
yeah, but I think my cutoff, if I'm absolutely needed to provide dual antiplatelet therapy, I think my cutoff would be closer to 100,000 platelets, and I would definitely would not add it if the platelets are less than 50, because mostly because I'm wanting to see what else I can gain from it. I think if I can gain plaque stabilization with the presence of a statin or potentially aspirin alone, that may be enough. Later next, I'm going to talk a little bit about the different types of phenylpyridines in whether or not to use clopidogrel versus ticagrelor or things of that nature, because as you know, each one has a different potency, and I think that's where the platelet count becomes incredibly important.
Great, thank you so much.
Mm-hmm. And just like we're having this discussion, I think the multidisciplinary discussion is incredibly important, because as an interventionalist, my definition of success will be very different from the definition of success that a cardio-oncologist, a clinical oncologist, a clinical cardiologist, or an oncologist will see in the future. So we have to make sure that the goals that we all set are similar, because if not, we're not going to be able to make everyone happy, quote unquote. And then we also will need to decide at some point in time whether or not therapy of palliation may not be unreasonable.
No, I think these are very important parts to put into the equation. So, the equation includes, what their counts are, what the intensity of your antiplatelet therapy is, what's the intensity of your vasodilator type therapy that you're using, and then the outcome and the planned treatment coming forward, et cetera, et cetera. So there's a lot of parts to that equation.
And also understanding when the next dose of chemotherapy will be, and do we have to hold chemotherapy in order to be able to perform the procedure safely, I think is also something that is incredibly important. And sometimes in the cath lab, we lose that understanding.
Yeah, no,
Alan,
I think.
Mm-hmm.
Go ahead.
Yeah, Stephanie Feldman had a question. Stephanie, you want to jump in? And
Sure, thanks so much. So I was just wondering, I know we're talking about dual antiplatelet therapy, particularly with the P2Y12, and I know it hasn't really reached mainstream in terms of using compass dosing rivaroxaban, but I think it's coming for our non-cancer patients. I'm curious what you think about that as part of the OMT regimen.
So that actually is also a great question. Rivaroxaban, I think, is getting much more press on the utilization for prevention of further coronary events. I don't think yet it's been used as mainstream. It may happen in the near future, mostly because of a potential risk of bleeding. I do think that cardio-oncologists and oncologists are much more comfortable using anticoagulants because of the intrinsic hypercoagulable state that are addressed. Normally, in the cath lab, we want to shy away from them as much as possible, particularly in the peri-procedural area. But I do think that will likely have a role without a doubt.
Great, thanks so much.
And then if we do decide that we're going to perform coronary angiography, I think the idea of making sure that placing or performing a percutaneous coronary intervention is the right reason to do it. Assess the hemodynamic importance of a lesion is incredibly important, either by FFR or IFR. Potentially, we could do these things from CT in order to specifically guide which patients should undergo an interventional procedure. And like everything, I think procedural optimization is mandatory, mostly because you want to prepare upfront the patient for an important procedure. Keep an eye on their blood counts. Try to time this to avoid the nadir of the effect of the chemotherapy. And I think the discussion of drug-eluting stents versus bare metal stents is incredibly important. And that I hope to dispel some of the earlier fears or thoughts that we had. So if you guys remember, bare metal stenting has now been available for close to 30 years. And drug-eluting stents have dramatically changed the way that we practice after their appearance in the early 2000s. And the first generation drug-eluting stents, were stents that were made out of thick metallic struts. Their inflammatory was, their polymers where the medications were eluted in were very inflammatory prone, which caused a fair amount of inflammatory reactions at the level of the endothelium, and then caused either delayed hypersensitivity reactions and delayed stent malapposition. And also, we didn't really know exactly what dose was appropriate to inhibit in-stent restenosis. And as a result, we used stents that had high doses of very potent medications like paclitaxel and sirolimus. Now, 2 generations have passed since then, and our current generation drug-eluting stents are made out of thinner struts. They now either have an inactive polymer that is not prone to inflammation, or a bioabsorbable polymer that then basically disappears after a short amount of time after the medication is eluted. And as a result, the presence of the hypersensitivity reactions at the level of the endothelium have disappeared. In addition, it is rare that we use paclitaxel, and now we use mostly sirolimus derivatives. And out of those, we have both everolimus and sotarolimmus eluting stents. And these cousins of sirolimus actually maybe a little bit more are dosed in a little bit of a more vasoreactant dose. And because of that, we now know that sotarolimmus eluting stents are actually approved to just be given a very short amount of dual antiplatelet therapy. So you can place a stent that is covered with sotarolimmus and then stop the dual antiplatelet therapy in a matter of a month, without necessarily having the rate of restenosis that you would see with bare metal stenting and stopping the antiplatelet therapy at the same amount of time. So there is an indication now in the United States for the Medtronic Resolute Onyx drug-eluting stents for stopping dual antiplatelet therapy at 1 month if patients have a high risk of bleeding. The other stents, the everolimus stents, those are the Synergy stents from Boston Scientific, also have potential indication, not necessarily indication, but potential, there's data to support the discontinuation of antiplatelet therapy if bleeding is of high risk within a short amount of time, between 3 and 6 months. So the use of a bare metal stent, because we think that we can stop antiplatelet therapy earlier, may not necessarily be warranted anymore, mostly because these newer generation stents can give you the same amount of DAPT duration plus the prevention of in-stent restenosis. So in our practice here at our institution, it is very rare that we use a bare metal stent anymore for any individual. From a procedural perspective, I think radial PCI has definitely increased in frequency everywhere in the world, and potentially using access or access techniques that would minimize your risk of complications, particularly in patients who are more prone for bleeding, is incredibly important. If radial access is available, I think radial access should be a first choice. If radial access is not available, or the type of procedure that we're doing requires large bore accesses that would preclude radial artery canalization, femoral artery canalization under ultrasound guidance is appropriate. One of the things that we forget is the effect of chemotherapy on the radial arteries or any other arterial tree also is pretty important. And the vasospasm that can be seen is also quite dramatic and may lead to other complications if we manipulate the radial artery unnecessarily. The dual antiplatelet therapy duration is key, and I think potentially continuation of antiplatelet therapy for the longest amount possible is always the best. But if you need to cut down on the duration, definitely using stents that would allow you for early endothelialization and low risk of stent thrombosis is appropriate. So potentially use stents that can be that are approved for a 30-day DAPT duration, I think is critical. And as you know, we have prasugrel, ticagrelor, and clopidogrel, which are written here in their potency order. And I would be very hesitant to use prasugrel in patients whose platelet count is exceedingly low or continues to hover on a lower range, mostly because of the risk of bleeding complications. I think ticagrelor is better than clopidogrel, particularly in patients who present with acute coronary syndrome or on STEMI, but also their administration will make them more prone to bleeding. And particularly if you have patients who need to be anticoagulated for a particular reason, the studies that evaluated antiplatelet therapy and anticoagulation are mostly centered in the utilization of clopidogrel. Only 5% of the patients enrolled in the large anticoagulation trial actually received the ticagrelor, and the majority were using clopidogrel. So our mainstay in therapy for these patients are the utilization of clopidogrel. And then if patients need to be anticoagulated because of atrial fibrillation or because of a DVT or other reasons, we prefer to use NOACs over warfarin and combine the NOAC with clopidogrel. Apixaban is simple to dose, and apixaban is simple to use and has very good data with the administration of clopidogrel. As far as intraprocedural anticoagulation, I think the use of heparin versus bivalirudin is relatively controversial. I think we want to make sure that we use anticoagulation that becomes therapeutic and eases off relatively quickly, and we do not want to over anticoagulate patients. So ACT monitoring is definitely appropriate and should follow a target ACT of between 250 and 300 seconds during the procedure. So radial access, I think, should be first line, particularly if we think that is what is safest for the patient, unless either we can't get it or we don't think that the type of procedure that's mandated will be able to be performed safely with a small sheath. utilization of either hemodynamic assessment or intravascular ultrasonography or optical coherence tomography is incredibly important to make sure that our stent length and stent apposition is critical and perfect, because we do not want to have complications of stent thrombosis or associations with malapposition. So we have to make sure that, like every patient, to do an excellent job, but using these other techniques to enhance our results are incredibly important. Definitely try to use a small amounts of dual antiplatelet therapy, and use the drug-eluting stents that are approved for shorter duration. Consider a short amount of DAPT and maximization of medical therapy during the treatment of cancer. And once again, talk about the multidisciplinary component. Now, that's for chronic stable angina. For
Hey, Dr. Zejarias. Oh,
yes.
Excuse me. Yeah, quick question. So in your practice, or how frequently do you use IVUS and OCT for these types of cases? You know, patients with malignancies requiring PCI.
So we use IVUS in our lab very routinely. We're probably one of it's an exception. If you were to compare us with the rest of the United States, we probably use IVUS in close to 80% of our cases. It is very rare that we do not, irrespective of whether or not patients have cancer or not have cancer. We feel that the results are better in the type of procedures that we do. We feel strongly that optimization is critical to confirm that we're having a good result. So we use it incredibly frequently.
Perfect, thanks.
And interestingly enough, the amount of patients, or the number of patients who have received primary PCI or PCI for acute coronary syndrome, has actually increased over time. And interestingly enough, the mortality has decreased. Whether or not that's because of patient selection or because of optimization of our procedures is difficult to know. As you can see here, the survival in patients who have a malignancy and then have PCI is much better than those who are treated medically. So it's either we're getting better at it, or potentially we're able to triage them a little bit better in order to select the patients who will benefit the most from it. But I do think that having a malignancy does not preclude you from having a coronary intervention. But we just want to make sure that we all agree on what is the best course of action for the next hurdle or step to take. You know, treating somebody with a PCI when they're presenting with an SC segment elevation MI will likely increase their survival from a cardiac perspective. But in a bigger picture type of situation, we do want to make sure that patients want to take that extra step for the next step that will occur in their cancer treatment. And sometimes in the rush of treating patients quickly, we tend to obviate that question and not worry about it. And I think patient decision or patient input in this multidisciplinary assessment is very important.
So Alan, there's another question that seems to have come up recently, at least in our experience, in particular in the last, I would say, last 6 months or so, that patients with prostate cancer who are getting abiraterone or enzalutamide, some of the newer anti-androgen therapies, they come in with an acute coronary syndrome, not necessarily an ST elevation infarct, but certainly worsening angina, and have you know, evidence of troponin elevation and that kind of thing. And they go for a stenting procedure. Is there a period of time that we should, and it's unknown if it's related directly to those therapies or whether it's just kind of an unmasking of underlying coronary disease. And so I've had a difficult time deciding whether or not I would advise the oncology team to hold that therapy. And so what I have done is sort of, generally individualize it, but for the most part, I've told them to hold the therapy for a couple of months. Now, I don't know what you think about that, and whether, because in other instances where we think that there is cardiotoxicity that's occurring, for example, Herceptin causing LV dysfunction, we might have a period where we hold therapy while we introduce cardioprotective treatment and then, resume therapy at some later point. So relating that to these newer prostate therapies, is there a period of time that we should hold therapy until we, stabilize their coronary situation?
I think in those cases, it's not unreasonable to hold therapy. Now, the duration of holding the therapy is always complicated, mostly because I don't think we know how long these effects will last for, right? But I do think that holding therapy, particularly in somebody who's going to have a PCI, will be incredibly important, because those, as you saw, prostate cancer is associated with one of the highest bleeding rates after the procedure. So we want to make sure that we are at least giving the patients the full benefit of the revascularization strategy without having some other complications that arise from it. But yes, I think holding the medication at least until they're fully recovered from the PCI perspective is not unreasonable.
Great, thank you.
Hey, Alan, I don't know if you can hear me. Make a comment about the timing of surgery. Many of these oncology patients basically are going to be undergoing some major surgery, after their coronary disease is stabilized. And with the newer stents, is there any data whatsoever suggesting that surgery is safer sooner? In the past, it's been quite dangerous. Even 1 month, even at 3 months, there still is an increased risk. Any comments on that?
Yes, Dr. Kronberg. So it appears that the shorter duration of antiplatelet therapy is safer now with the newer generation stents. As I had mentioned earlier, the sotorolimo-eluting stent has now an FDA indication for 30 days of DAPT. The everolimus stent with the bioabsorbable matrix in the abdominal component, those are the synergy stents from Boston Scientific, tend to be able to decrease the antiplatelet therapy or stop the dual antiplatelet therapy at 3 months. So I think the presence of the the thinner struts and the type of matrix where the medication is eluted into has made a big difference in that. And I believe that the risk of stent thrombosis when we stop the dual antiplatelet therapy in that short amount of time is not any higher than what it was if we were to continue it for the longer period of time.
As far as surgery is concerned, you would feel more comfortable doing it. Obviously, you delay it as long as possible, but you feel more comfortable than we used to feel with the earlier stents.
Yes, much more comfortable.
Thanks.
So, complications are, sorry?
This is Isaac Gray. So some of these patients, they're going to be receiving some therapies that are going to deplete their platelets even further. So how comfortable are we after 1 month of therapy of DAPT, basically not going back on any for a fairly extended duration?
Well, so DAPT, the duration of DAPT for 1 month in these newer generation stents is safe. I think stopping all antiplatelet therapy is definitely not something that's been studied. So using at least aspirin for that time, I think would be appropriate. But I don't think you're going to find any, at least I don't know, sorry, I don't know of any data that says that you can basically stop all antiplatelet therapy after placing of one of these newer drug-eluting stents. All of them have a certain amount of antiplatelet therapy that is being administered.
Yeah, I think that question brings up a lot of potentially complex issues. So, for example, if it involves knowing what the cancer treatment is likely to be, and then knowing how urgently or how significant is the need to revascularize. So, to just give an example of where you may struggle with these issues is, say somebody has a new diagnosis of leukemia and they are either going to get therapy, or they you could anticipate that they're going to get therapy that's going to lower their platelet count below an acceptable level for many months, like a stem cell transplant. And in those patients, I would not do a stent in somebody who just has a 50 or 70% stenosis and no chest pain symptoms. I would say defer that procedure. But if they present with an acute coronary syndrome and you have to do something, then trying to delay the urgent treatment for their cancer, if you could delay it a few weeks so that they could get at least a month of therapy, is kind of one approach that we've taken to those situations.
Right, and that's what we're doing. Is for the month. If the question is after that month, when their platelets are 10 or less, we just
I think there's not going to be a study that's going to tell you what to do. But what we have done is, if the platelet count is 50 or greater, we would definitely keep them on aspirin. If their platelet count gets below 20, we hold everything. So in between 50 and 20, we generally would not use dual antiplatelet therapy, but we don't really have any data that says that that's how you should do it. That's just what we do.
Thanks.
The corollary situation would be in patients with liver failure who have hypersplenism. Now, unfortunately, in those patients, there are platelets that are potentially can be distributed to the body as they are all just caught in the spleen. So for those patients, we feel more comfortable using the APT, as Dan had mentioned, until the platelet count drops below 50, and then we begin to think about it twice. But I don't know of any study that says that mentions the exact number or the reactivity that's required for a platelet to cause stent thrombosis. And then I think that's where I would maybe defer to you guys a little bit more from that component. Also, in patients who need the anticoagulation for another particular reason, it appears to be safer to be able to maintain them on some amount of anticoagulation if that is going to be the precluding factor causing a large complication that may actually facilitate their treatment.
A great talk, Alan, and lots of great points. This is Josh. So the sad part is there aren't any studies that I'm aware of that show how many platelets are needed to cause a stent thrombosis, but we definitely have patients that we see inpatient that have a ST elevation MI with as little as 1 platelet, which is disconcerting for sure. And I guess just to at least add to the discussion, there are no true studies that have looked at a threshold for starting aspirin or dual antiplatelet as everyone is suggested, but there have been some other arbitrary guidelines that have been put out there. So I just at least add them to the discussion, which is using aspirin for anything over 20,000 or dual antiplatelet for over 30,000. And I've usually used those, especially if the situation's more acute, and I haven't had any issues with those. But there's a big difference, obviously, as people have already mentioned, between the acute patient and the stable patient and what level of risk of bleeding we're willing to accept.
Yeah, Josh, those are very good points.
I would like to, this is Ron again, Crone. Just another point which you're making in the third bullet point, which is the multidisciplinary efforts. But I think that needs to be expanded on these patients when they go to the cath lab, because so often, at least at our place, as you well know, ad hoc PCI is almost the rule, it's absolutely essential that there's a direct communication between the cardio-oncologist and the interventionalist, so that everybody's on the exact same page as to how to handle the patient. Because as you have described, these are very difficult and complex decisions to be made, and also you need to know what's coming for that patient. And often in the cath lab, since this is the interventionalist may not be aware of all of the nuances. So it's absolutely essential that there be a direct communication with that operator before and even after the study is done, in order to plan the therapy right then. And that's been very successful at BJH, but I think it's important to emphasize it. Multidisciplinary efforts is interesting, but I think you really need to have a direct statement that the cardio-oncologist or the cardiologist dealing with that patient and his cancer needs to have a direct communication with the interventional operator. And I think this has been a wonderful talk, Anna. Thank you very much.
Thank you, Dr. Gordon. And yes, I think, we as the proceduralists don't always understand the nuances of what's required of the cancer therapy, and that communication is key.
Yeah, I think one other instance where this what you're saying is critical is sort of for example, if you look at the timing of chemotherapy and preparation for surgery, in say, for example, gastric cancer or esophageal cancer or something like that, where they will undergo 2 or 3 months worth of chemotherapy, and then they'll get about a 4-week pause, and then they'll have surgery. And all during this time, if coronary artery disease is becoming an issue that you have to manage, you have to look and see how does a potential PCI impact those decisions, because chemotherapy and preparation for surgery and those types of cancers is critical, the timing. So they can't let 3 months go by or 6 months go by after they finish their chemotherapy in order to proceed with their surgery. So there are a lot of subtleties that need to be communicated to the interventional team, just so that everybody understands where we're at.
Hi, sorry. I am Hadi Skouri from Lebanon, Beirut, Lebanon. My question is about optimal medical therapy. I may add ivabradine, Procorolan or ivabradine. It's a definite channel blocker because patients with chemotherapy and cancer, they have intravascular depletion, they have low blood pressure, they have anemia as stated, and their blood pressure is on the lower side, and they get admitted with sepsis, infection, etc. So beta blockers and calcium channel blockers can lower blood pressure more. So in these patients, the prevalence of tachycardia is high, so I may add this medication as it has no side effects to lower blood pressure too.
Yeah, that's actually that's one of my personal favorites. The difficulty is in the United States that you can't get that medication very easily.
Yeah.
And actually, that medicine tends to raise your blood pressure a little bit because it sort of combats autonomic dysfunction. So I think that we tend to use that medication fairly frequently, and so I'm a big fan of it, especially when you are dealing with somebody that has a low blood pressure. So I agree with your point.
Okay. And one other thing, I heard the discussion concerning if we stop chemotherapy after a myocardial infarction and stent placement or PCI, there is no guidance for how long we have to stop, or in which chemotherapy we have to stop, or do we have to continue with dual antiplatelet therapy?
I don't know. This is a complex question, and it's basically the one I asked Alan earlier. So yeah, I don't. There's
So
there's nothing published that I could tell you. It's just decisions that we have to make.
So one individualized patients accordingly, up till now, depending on platelet count and depending on the risk of bleeding in these patients. So,
Yeah.
yeah, and I think the cutoffs that were mentioned, that
yeah,
less than 20,000 platelets should definitely stop any antiplatelet therapy. Are reasonable. Those are part of the the recommendations from SCA and I that were published now almost 2 or 3 years ago. But whether or not to continue it when the platelet count is less than 50, maybe just use single antiplatelet therapy as opposed to dual antiplatelet therapy, I think is not unreasonable. And that always makes us, forces the question to be asked. Well, is really revascularization going to be the best strategy, right? What is the amount of myocardial at risk if we're talking about somebody who has who's undergoing an elective procedure? And that's why we try to make sure that we do not necessarily just go to perform PCI, or in patients who had who are having an active evaluation for neoplasm, try to make sure that that evaluation is completed before we go ahead and proceed with a stent-guided therapy of the coronary treatment.
this is in stable coronary disease or stable angina, but in unstable or acute coronary syndrome or ST elevation, we have to intervene.
Yes, for that you have to intervene. Agree.
Yeah.
Thank you.
Yeah, this is Ryan Cronin again. Another comment. When stents first came out, at least the drug-eluting stents came out, there was a concern that chemotherapy would be inhibiting basically endothelialization of the stent and may prolong the period when the stent is exposed to the blood, and that would lead to stent thrombosis. And so I don't think that there's been really much done on that since the early days of stents, when there was some use with the angioscopy and whatnot showing that the stent was still visible a year later in the vessel. But the question is there any evidence that resuming chemotherapy would lead to a stent thrombosis? I'm not aware of any. I mean, it's one of those things you can think about and keep yourself up at night without really having any data. And I'm not sure how you deal with it, but it is, if anything, it's a reason to continue double therapy, DAPT, longer than you might otherwise if you're able to do it in the presence of a chemotherapy and a new stent.
Yeah, Dr. Ronso, I'm not certain that there's been any angioscopy studies performed, as you had mentioned, but we do know now that the underlying materials where the drug-eluting stents are made up of or comprised of currently are much better than what they were initially, because of our understanding of the of the effects of the sirolimus or the paclitaxel. So that's why the lower dose of medications or the less potent sutrovolimus or everolimus can potentially promote more of that endothelialization.
Thank you.
Well,
all right, Alan, it's I'm sorry, it sounds like we have one more question.
Yeah, I'm sorry, can you hear me?
Yes.
Hello?
Yes.
Hello, can I ask a question?
Yes, please.
Yeah, I'm Dr. Iqbal from Sri Lanka. I'm an oncologist. My question is a little bit of like a repetition question. If a cancer patient, while on dual antiplatelet therapy, if their platelet count dropping frequently, what's your suggestion? Which antiplatelet we need to take it off or remove if platelet count is more than 50? Either clopidogrel or aspirin, which one is better to keep?
I think the better to keep is likely going to be clopidogrel.
Okay, okay, thanks.
Well, Alan, thank you so much. This has been really wonderful, and we greatly appreciate all of your help every day in our patients, and you provide your expertise. We greatly benefit from that. So I'm glad that you were able to share it with the world here. So thank you so much.
Well, thank you.
Thank you, Dan and Jose, for the invitation. It's always great, as I said earlier, to be able to work with you guys, because you do really phenomenal stuff, and there's no bigger patient advocates than our cardio-oncology team, and I really mean that.
Well, thank you for saying that. We didn't even have to pay you to say that, so that's good. All right. Well, thank you all. And Steve, do you know what we have coming up next time?
Yeah, and I meant to say at the beginning of this presentation, for the next 4 weeks, so including today, the next 3 weeks now, this time slot will be focusing on different surgical procedures related to cardio-oncology. And then next week, next Thursday, we'll have another journal club discussion. So thanks everybody for joining.
All right. Thank you all so much. Appreciate it. See you next week.
Thank you.
All right.
Bye-bye.